Is our next exam next week? Wednesday,
Mhm,
I'm gonna start that then.
mhm.
I definitely thought I left them there. So. Very nice. I walked out and I was like. "Yeah." Do that like. I'll go back, like, put my watch on the charger. And then, like, maybe I have to go like 5 in the morning. It's so. Got there.
So the next exam, demo green. Sure goes right, oh yeah. Oh no, not bad. You said it is one.
Okay, let's look. Yeah.
Mhm, look.
So.
Okay. Oh, it's no one.
Yeah. I don't know. I don't know anything not to say, I'm not doing this. Yeah. I'm not, like, I'm not, like. But I'm also like. Next one's.
Very good. It's time to start. Is that too cold for anybody? Does anybody want that closed, or do you like the fresh air? It's good. All right, we will leave it open. They're not running the lawnmower, so if they're running the lawnmower, I'd shut it, but they're not. So I'm kind of a fan of the fresh air. I have a sweater on too, so that helps as well. We'll keep that open. Did you guys enjoy that extra hour of sleep?
Those vibes.
I sure did. I sure did. So we have a test a week from Wednesday. Week from Wednesday. Is that a problem for anyone?
Well, I mean,
Schedule wise, that is not whether or not you want to take it.
Can we do the Friday? Can we switch
The
it
Friday is better for you.
For ENS? I won't be here.
You won't be here.
What, like.
Like the 16th?
Sorry,
16?
16th.
I will.
So if we do it Friday, it'll be a bunch of you who won't be here.
Oh, I might not be.
You not be here either.
Maybe, no, Wednesday, maybe,
Oh, perfect.
because we're traveling to Rains, like one time in the evening. I can figure that out today.
Okay,
Or you could take-
so if we do the test on Friday, I will have to have it earlier, available earlier, so you could take it earlier. Yes?
Yes.
No.
All right, what I might do then is just send the test to the Academic Student Connection, Academic Support Center, sorry. And then just have them administer it as needed for those of you who won't be here on Friday, and then just have the test on Friday.
Is that the place below the food area? Okay, it's right. That's fine.
So we had this go sometime.
You make an appointment, you have to make an appointment with them because they have many people to whom they must distribute tests, so it works much better for them if you make an appointment. If you can't get an appointment before, you'll have to wait essentially the next week and take it the next week. So my advice to you is make it early. So let's say you won't be here that Friday, so Savannah, you for sure, Annika, you for sure. So two of you, and you won't be here Wednesday, but you will be,
I'm not sure what time we're leaving Wednesday.
okay, but Friday you will be here.
Yes.
All right,
Yeah.
okay, so
We can take it like after class on Wednesday.
if you can't get an appointment to take it, but do you leave before Friday or on Friday?
We leave Thursday.
Oh gee, that kind of narrows your options down, doesn't it? Well, I guess you really don't have an option, do you? Right, so, yeah, but make sure you call them and set an appointment up as best you can. Thank you for those of you who've got your flu shots. I've got your emails and hopefully
I'm getting it.
I've gotten that into the
You get it to send it
Blackboard and what have you. So, right, so Olivia is on Zoom, so everybody say hi to Olivia. Olivia's waving wildly, so
What will the test be over? Which chapters?
so
Like through
the
which
test
chapter?
will be, since then, we've covered the endocrine system. And we will by then have finished the circulatory system. So it sounds like it'll be just those two chapters. Well, three chapters, because cardiac output is its own chapter. I don't have my book with me. I can't tell you which chapter it is per se, but I'll figure it out.
Okay.
Right.
Word.
All right. So we are going to talk about the conduction system in the heart. To finish the heart sounds, remember that the first heart sound is generated by the closing of the atrioventricular valves, the tricuspid on the right side, the bicuspid on the left side. The second heart sound, the dub of the lub dub, are the semilunar valves, the aortic and pulmonary valves. Depending upon where you listen with the stethoscope, you can split those sounds. That's called the splitting of the heart sounds. Those of you who have had the EKG class have probably heard splitting of the heart sounds depending upon where you listen. And then if, again, we talked about pregnancy will cause an extra heart sound as well because the heart enlarges during pregnancy. That's reversible. And then we listen to some abnormal heartbeats. The two that we made reference to in particular were aortic stenosis. This is very common in older people whose aortic valves get calcified. That calcification narrows the outflow of the heart. And clinically, this is again, Baratovich stupid mnemonics. The clinical triad for aortic stenosis is SAD, syncope. Syncope, if you don't speak fluent med talk, is fainting. D is dyspnea. And A is angina. Dyspnea is being short of breath. Angina is chest pain. substernal chest pain, a crushing substernal chest pain. That triad, the SAD triad, is characteristic of aortic stenosis. And stenosis, remember, means narrowing. Somebody asked, can aortic stenosis occur in a younger person? The answer is yes. Some people are born with a congenital bicuspid aortic valve. This congenital bicuspid aortic valve can undergo premature calcification that can cause aortic stenosis in a younger person as well. So that's an unusual case. Usually this occurs in older patients. And the treatment for it is a valve replacement, which nowadays is pretty routine surgery. Angina is a substernal chest pain. Crushing substernal chest pain usually occurs with exertion. And is usually relieved by rest, usually, unless it's a heart attack. In fact, that's one of the state distinguishing features of a heart attack. Okay, a little clinical feature here. How can you tell if someone's having an angina attack or heart attack? You give them cardiac nitrates, you give them sublingual nitroglycerin. If the angina goes away, it's angina pectoris, it's not a heart attack. Doesn't go away, it's probably a heart attack. Of course, there's the whole EKG thing you want to check as well, because other things can cause chest pain as well, like a zoster infection or something like that. So you switch from cardiac pain to the queen mother of all headaches, because nitrates cause vasodilation around the brain, and it gives you quite the headache. The other pathology that we looked at, there's others we could talk about, these are just the two we picked, is aortic insufficiency. This causes regurgitation. When the aortic valve tries to close, it doesn't close all the way. You get regurgitation from the aorta back into the ventricle. This can be caused by things like something called aortic dissection can cause this. Aortic dissection would be a separation of the inner layer of the aorta from the outer layer. That's aortic dissection. That can cause aortic regurgitation. Anything that widens the aortic root, so aneurysms, also syphilis, will do that too. Infective endocarditis that inflames the valves and then causes them to shorten, thicken and shorten. That can cause also aortic insufficiency. Chronic rheumatic fever is also an important cause of that if you had rheumatic fever. So patients with aortic regurgitation, remember for aortic stenosis, we heard it, you get the systolic click and the crescendo decrescendo murmur. It's a systolic murmur. With aortic insufficiency, it is a early decrescendo diastolic murmur. Early decrescendo diastolic murmur. The diastolic murmur is caused by blood flowing back through the valve into the ventricle. Because blood is flowing back into the ventricle, you get increased stroke volume. That's going to increase your systolic blood pressure. And patients may feel kind of like let me feel the pounding pulse, hammering pulse. The bounding pulses, some patients, because their heart pulse, they can hear their heartbeat, and they'll sometimes head bob to the heartbeat. So if a patient comes in and they're head bobbing and you can't explain it and they don't have any earphones in, that might be it. Can you hear your heart rate? Yeah. Might be aortic insufficiency. You may even see capillary beds pulsing in the fingernails. That's called a Quincke sign. That's also a clinical sign of aortic insufficiency as well. If this is not treated, the heart will remodel and get larger. It'll undergo hypertrophy. All right, we talked a bit about rheumatic endocarditis, about streptococcal infections. That's pretty much, I already talked about those. That's as much really as I'm going to say about those right now. Okay, electrical activity of the heart. So in order for the heart to beat, it needs an electrical signal that causes the cardiomyocytes to depolarize and contract. Because the cardiomyocytes are linked together by intercalated discs that are decorated with gap junctions, electrical ionic changes that occur in one cell will spread to all the other cells. That's why we call it a myocardium. The myocardium acts like it was one big cell. So we call that a functional syncytium. A functional syncytium. So the beat is set for the heart by a small group of cells in the upper part of the right atrium called the sinoatrial node, sometimes known as the sinus node. The sinus node. The sinoatrial node cells act as the pacemaker for the heart. These cells have a capacity to spontaneously depolarize. You can put those pacemaker cells in a dish and they'll actually depolarize all by themselves. Other cardiomyocytes need a current to come to them. These cells don't need a current to come to them. They can generate the current all by their lonesome. And here's how they do it. So the membrane potential for these pacemaker cells will be somewhere around 65 millivolts or so. The cell, the pacemaker cell, is going to gradually depolarize to around about minus 50 or so millivolts. And that minus 50 or so millivolts is going to be the threshold potential for those cells. How, in fact, do they do that? The spontaneous depolarization is due to a set of sodium channels. These are special sodium channels. They're almost like a leak channel, except they're regulated. They're regulated by cyclic nucleotides, in particular cyclic AMP. So these are called HCN, or hyperpolarization activated by cyclic nucleotide gated channels. I hate that. It's way too long. We're going to call them HCN channels, because hyperpolarization activated cyclic nucleotide gated channels is just ridiculous to say all the time. We're going to call them HCN channels. For the more chemically minded amongst you, hydrogen cyanide channels. Because HCN in chemistry is hydrogen cyanide, but this has nothing to do with hydrogen cyanide. HCN channels. So these HCN channels, as you can see, are responsible for the pacemaker potentials. This electrical current is caused by a flow of sodium ions into the cell. This current is called by electrophysiologists the funny current. The funny current. Because you can see it goes from resting up to threshold, just kind of eerily, just spontaneously does that. So that is called phase 0 of this pacemaker cell cardiac cycle. It's like the cell just kind of drifts up to minus 50 millivolts. Very odd. So once it gets to threshold, the cell will now depolarize, and it depolarizes because voltage gated calcium channels will open and calcium will rush into the cell. So with sodium and potassium and sodium and calcium coming into the cell will depolarize and will peak out past 10 millivolts. This happens very quickly. And it doesn't last very long. It only lasts about half a millisecond. The calcium channels remain open until they get to about plus 10 millivolts, at which point they start to close. That's phase 3. Phase 3. What happened in phase 1 and 2? They don't have a phase 1 and 2. They just have a phase 3. Once we get to that phase 3, the end of that phase 3, now we're going to have the closure of the voltage gated calcium channels and the opening of the voltage gated potassium channels. Potassium will now leave the cell, and it will leave the cell quickly. That will bring the cell back to the resting potential of about minus 60 or so millivolts. And the potassium channels by this time have closed completely. And now we're back to the funny current due to the HCN channels. That's the pacemaker cell electrophysiology. The pacemaker cell electrophysiology. This is very different than non-pacemaker cells. So don't get this confused with non-pacemaker cells. This is the pacemaker cell electrophysiology. So there's two different types of electrophysiological profiles in the heart. The pacemaker cell electrophysiology, the non-pacemaker cell electrophysiology. This is the pacemaker cell electrophysiology. Please don't confuse the two. Non-pacemaker cells don't have HCN channels, just the pacemaker cells. They're special. Now, once those cells depolarize, all the other cells that are connected to them via gap junctions are going to have what happen to them? They're going to depolarize. They're going to depolarize because that calcium is going to not stay in the pacemaker cells. They're going to leak to all the other cells that are connected to them. So they'll get depolarized and it'll spread throughout the entire atrium.
What do the non-pacemaker cell potentials look like? Do you think there will-
We'll get to that.
Okay.
First things first.
So the calcium leaks through the gap.
Mhm. So these channels are called fast calcium channels or T-type calcium channels. So you can think T means T for terrifically fast. Okay, then we open the potassium gates, potassium is in, we repolarize, and then we're back to phase 0 again. So we have 0, 3, 4, 0, 3, 4, 0, 3, 4. Now let's talk about the non-pacemaker cells. These have a resting potential of about minus 90 millivolts. Very different than pacemaker cells. Threshold for these cells is minus 70 millivolts. And when they're at rest, they are at phase 4. Phase 4. Once they get to threshold, which they get to threshold because calcium comes into the cell from their neighbor, they will then get up to threshold, minus 70 millivolts, and their own VG sensor voltage gated. Their own voltage gated sodium channels open, and the cells depolarize very quickly to about plus 20 millivolts. That is phase 0. Phase 0. So the myocardial cells, non-pacemaker cells, depolarize quite quickly, but then something funny happens on the way to the bakery. Voltage-gated calcium channels open. Now you have potassium leaving, calcium coming in, while the sodium channels have closed. That's going to take repolarization, it's going to stretch it out. This is now called phase 1. It is the plateau phase. The plateau phase. And these particular channels are called slow calcium channels, L-type calcium channels. They're losers because they're slow. So they're L-type. Again, these are my dumb mnemonics. I have no idea if these will help or not, but. So T, fast, L, slow. They're slow because they're slow at closing. So that 1 to 2 is the plateau phase. The plateau phase. We have the fast, the polarization phase, and then 1 and 2 are the slow phase. By the time we get to phase 3, the voltage-gated calcium channels, slow channels, have closed. And the voltage-gated potassium channels are open, so potassium is leaving the cell. The cell now depolarizes at a pretty phase clip. So phase 3 is repolarization. Phase 1 and 2 are plateau. Phase 0 is depolarization. And phase 4 is resting. So resting to threshold, phase 4. Depolarization, very fast depolarization, phase 1. Phase 1 is a beginning of repolarization, beginning of plateau. Phase 2 is a slow repolarization, plateau phase due to the slow calcium channels. Stage 3, full repolarization, back to stage 4. And notice your pacemaker cells did not have 1 and 2. Pacemaker cells do not have slow potassium, slow calcium channels.
Which one did you say you didn't have one? It's a phase 2 that doesn't have it?
Pacemaker cells do not have phases 1 and 2 because they don't have slow calcium channels. So during that phase 2, you have calcium channels that open, and that influx of calcium channels counterbalances the potassium ion efflux. That's what causes that plateau phase. All right, so if I gave you this picture, asked you to label it, think you can do that? No?
That's a problem.
Probably. You take those numbers off. In fact, this is a way you could study. You could just draw this or trace it on a piece of paper, photocopy it a bunch of times, leave it around the house, and then just when you run into it, see if you can label it. That repetition will help you remember it. Clinically speaking, there are drugs that inhibit these channels here. You inhibit these channels here. Now your depolarization is going to get a lot slower. Those types of drugs, they slow the heart down. They're used for malignant tachycardias. You want to slow the heart down. So drugs like lidocaine, yes, lidocaine, it's not just topical anymore. Lidocaine, quinidine, disopyramide, drugs like that. Flecainide, propafenone, things like that. They will take this graph, and they will push this like this. There are other drugs that inhibit the potassium channel. So they're going to take this and pull this way out. They're also going to slow the heart way down. Amiodarone, very, very commonly used drug after a heart attack to prevent the arrhythmias. that come from heart attacks. They inhibit the potassium channels. And then, of course, calcium channel blockers, they're going to inhibit the slow calcium channels. Drugs like diltiazem, verapamil, drugs like that, and what have you. Now, cardiomyocytes have a physiological quirk that skeletal muscle cells do not have. Skeletal muscle cells depolarize because you have ligand-gated channels that bind to nicotinic acetylcholine receptors. That local depolarization then causes voltage-gated sodium channels to open. That depolarizes the whole muscle cell. When the cell depolarizes in the T-tubules, you have a physical link between the voltage-gated channels and the calcium channels that let the calcium out of the sarcoplasmic reticulum. That's not the case in cardiac cells. In cardiac cells, once calcium rushes into the cell, the sarcoplasmic reticulum has special receptors that are ligand-gated channels, but the ligand is calcium. So when calcium levels go up inside the cell, internal stores of calcium are going to gush into the cytosol. This is called calcium-induced calcium release. And this is another reason why you have a plateau stage, to make sure you get enough calcium into the cell so that the internal calcium stores can be released, because that calcium helps the sliding filaments contract. Skeletal muscle cells do not have this. And the receptors responsible for letting calcium out of the sarcoplasmic reticulum are called ryanodine receptors. They're called ryanodine receptors because you can open them with a small molecule called ryanodine. And that is used in research to get the sarcoplasmic reticulum to dump its calcium. In fact, experimentally, if you want to get heart cells to beat, a little trick you can use is give them a calcium ionophore. There's several you can buy for an exorbitant price. They'll insert into the membrane like calcium in, and the cells will start beating because of that calcium-induced calcium release. Calcium is returned to the sarcoplasmic reticulum by a pump called the sarcoplasmic reticulum calcium ATPase, affectionately known as SERCA. SERCA. And that is a primary active transporter that just pumps calcium very quickly back into the sarcoplasmic reticulum. So the calcium release channels, those are your ryanodine channels. And here's SERCA doing its returning calcium to the sarcoplasmic reticulum thing. All right. And then the gap junctions between cardiomyocytes guarantee that it spreads throughout the myocardium. Now we have a problem. Well, your heart has a problem, actually, which means you have a problem. You have that fibrous skeleton between the atrium and the ventricles. So the ventricles will spontaneously depolarize and contract. Is that going to make its way down to the ventricles? No, you need an extension cord that goes from the atria to the ventricles. And so your heart has a special conducting system from the atria through the septum down to the ventricles. This is the heart conduction system. The conduction system consists of specialized myocardial cells that are modified to conduct more than they contract. Cardiomyocytes can conduct, but they mainly contract. These cells contract more than they conduct. So throughout the atrium, from the AV node, you have pathways from the SA node to the base of the right atrium, and there is a bundle there for that will take the signal down to the ventricle. That bundle is called the atrioventricular node. The atrioventricular node. From the atrioventricular node, the signal to beat goes down a set of conductive tissues in the septum. And this pathway is called the bundle of His. Bundle of His. So the head of the snake is the AV node, and the snake says, His. That's how you remember it's the bundle of His. Then the snake is going to branch into two. It's going to be a two-bodied snake. It branches into the left and the right bundle branch. And bundle of His down to those two branches, again, through the septum. And then it's going to get to the apex, and then the left is going to go up the left side. The right is going to go up the right side. And those branches are then going to branch further into the rest of the ventricle. Those branches of the left and right bundle branches are called Purkinje fibers. Purkinje fibers. You can see this beautifully on this picture right here. This again is shamelessly stolen from the book. So they're not shown here, but you have some pathways that go to the atrioventricular node. There's the head of the snake. From there, it goes to the bundle of, what does the snake say? Not His. It's a German dude, so it's His. Respect the Germans. Then we have the left and the right bundle branch. Now, pathologically, you can have left and right bundle branch blocks. That will affect the EKG in a particular way, which we'll talk about here in just a bit. And then these go down to the apex and they swing this way. And then they branch. And those branches of these bundles are called Purkinje fibers. Purkinje fibers. They're going to essentially transmit this signal all the way up here, all the way up there. And that's how these folks are going to get the signal to contract. That's your conduction system. So the speed of conduction is going to vary throughout this system. The spread across the atria is pretty fast. Meter per second, pretty fast. It gets to the AV node and then there's a pause. It goes pretty slowly. That's to make sure the atria have contracted before the signal to contract goes down to the ventricles. That guarantees the atria contract before the ventricles. Once it gets to the bundle of His, the signal puts its running shoes on. And it goes very fast, 5 meters per second. So that when it gets to the Purkinje fibers, you get this rapid conduction of the ventricles at 1/10 to 2/10 of a second after the atria contract. So fast spread, pause, very fast spread, and then you get the ventricles contracting. Now, this electrophysiology of the heart can be detected by electrodes placed on the skin over the heart. And these electrodes provide a tracing that's called an echocardiogram, affectionately abbreviated ECG or EKG. EKG comes from the fact that it was first done largely by a German scientist, and cardiac in German is K. That's why it was called EKG, because electrocardio, the K was German for cardio. So people still call it EKG, but you also see books, ECG. EKG, ECG are the same thing. Now, there are 3 distinct waves in an ECG, EKG, a P wave, a QRS wave, and a T wave. The P wave represents the depolarization of the atria. The depolarization of the atria. The QRS wave indicates the depolarization of the ventricles, which is quite a bit larger than the P wave, which is not unexpected, since the ventricles are so much bigger. Then there is an interval after which there is a modest T wave. The T wave represents repolarization of the ventricles. So P wave, depolarization of the atria. QRS, depolarization of the T wave, repolarization of the ventricles. And if you were to take the action potential of the non-pacemaker myocardial cells, particularly in the ventricles, line it up, it would fit the EKG rather perfectly like this. Notice the uptick, the Q to R interval corresponds perfectly with the depolarization. This is phase, what phase? 0. And then the S wave is going to correlate essentially with the beginning. This is phase 1. And then the interval from the S to the T will pretty much correlate with 3. And then the T will be kind of sum of 3 and sum of 2 and sum of 3. So it gets down here to 4 over there. Now, there are several intervals that you need to pay attention to. There's the P to R interval, which is essentially the beginning of the P to the top of the QRS, the crest here. So here to here, that's the QR interval. Then you have the ST interval, the end of S to the end of T. Then there's a very important interval I should call your attention to, the QT interval, the beginning of Q to the end of T. There's several medications that increase the Q to T interval, and the increasing of the Q to T interval can increase your risk of ventricular tachycardia. So that's an interval that's quite important for electrophysiology. And then you have the Q, a P to Q segment, the end of the P to the beginning of QRS right there, and then the ST segment, and QRS to the beginning of T, that's the ST segment. And then the QRS complex, of course, beginning of Q to the end of S right there. Okay. And yeah, we said that. And this essentially shows you the tracing and what have you. Now, when you take the EKG class, instead of a 1 electrode tracing, you'll do a 12 lead tracing. Why do you do a 12 lead tracing? You do a 12 lead tracing because you're going to put electrodes essentially all around the thorax. That's going to give you electrophysiological snapshot of different parts of the heart. So if you were to see a water bottle from just that perspective, you wouldn't know how tall it is, would you? If you saw it from this perspective, you wouldn't know how big the base is. And if you didn't see it from this perspective, you wouldn't know how big the lid is. So by seeing essentially the water bottle from all these different perspectives, you're able to get an idea of the function of the heart and where it might be going wrong. So if, say, for example, you don't get proper delivery of the signal, say, to the bottom of the heart, where is the problem? Well, it depends where the lead is, which lead shows the abnormality. So, for example, V1 and V2, that's, third intercostal space down here and here. If you don't see proper electrophysiological function there after a heart attack, the heart attack has occurred, the heart has incurred damage in the septum, V1 and V2 issues. If you see damage in V1, 2, and 3, where is the issue? The issue is in the posterior of the heart. And if you see problems in, say, V3, V2 and V3 and AFL, then it is in the inferior part of the heart, the bottom of the heart. That's the problem. So essentially, by getting different snapshots electrophysiologically of the different parts of the heart, you can figure out where there's a problem and whether the patient might need a pacemaker and what kind of pacemaker and so on and so forth. And that's really all I'm going to say about EKGs. Questions about any or all of that? No? Very good. Let's look a bit now at cardiac output. So when we talk about cardiac output refers to the stroke volume multiplied by the cardiac rate. So the cardiac rate is simply the beats per minute. Beats per minute. And then the stroke volume is the milliliters of blood that you pump per beat. So if you put this together, you can see in terms of units, your cardiac output, I hope you can see, the units will be milliliters per pumped per minute. And those of you in physics right now are probably sick of dealing with units, but that's essentially how you deal with units. So your cardiac output will be milliliters per minute. So to just use this equation, what happens if the heart rate goes up? What the beats per minute goes up? What's going to happen to cardiac output? It goes up. It goes up. Stroke volume. Let's say the heart pumps more per beat. What's going to happen to cardiac output? It's going to go up. So cardiac output is directly proportional to stroke volume and cardiac rate. How can you increase the cardiac rate? You increase the cardiac rate through the sympathetic nervous system. The sympathetic nervous system input to the heart increases the rate. That therefore increases cardiac output. That's just an example of ways you can increase cardiac output. So the average blood volume is about 5.5 liters, give or take. And the ventricles will pump this at rest, essentially about every minute. So if you want to do a little navel gazing exercise, I don't recommend this because I don't recommend navel gazing. You could start your phone timer, take a look at your hand, and then just visualize blood there. And then after a minute, say, man, those corpuscles that were there in my finger, they've gone, they've left, they've gone back to the heart, and now they've returned. All right, that's navel gazing. I don't recommend that, but I hope it makes you just, as you think about it, just marvel at just how hard your heart works all the time, and that it doesn't take a break, it doesn't whine or complain, it just does what it does. During exercise, cardiac output will be increased, but will it be increased equally throughout the body? No. So if we take a look essentially at the heart and the circulation at rest versus the heart during heavy exercise. So heavy exercise would be a Bruce protocol, your legs are burning. That would be heavy exercise, which some of you in your HS classes have had to do, which is not very fun. So at rest, notice, because at rest, the parasympathetic nervous system is largely predominant. You have plenty of blood going to the GI tract. Notice that delivery to the heart doesn't really change. It increases because the heart's beating faster, but the percentage of blood delivered to the heart is not going to change during exercise. The amount will increase, but in terms of percentage, it won't change. Input to other types of tissues is going to vary quite a bit. Notice that at heavy exercise, input to the muscles is going to increase tremendously. Skin is largely going to be cut off during heavy exercise. The brain is also going to decrease in terms of percentage. Same thing with bones, same thing with kidneys, and the input to the GI tract is going to go way down. Now, this is due predominantly to the activity of alpha-1 adrenergic receptors and beta-2 adrenergic receptors. Alpha-1 adrenergic receptors, when activated, cause vasoconstriction. You have those types of receptors in the GI tract and in the skin. And they will cause vasoconstriction and will decrease blood delivery to these particular organs during heavy exercise. Skeletal muscles, on the other hand, have beta-2 receptors. Those beta-2 receptors, when activated, cause vasodilation. Therefore, you will increase delivery to these skeletal muscles during heavy exercise. The other tissues to which you have increased delivery during heavy exercise are the lungs. The lungs, because they also have large quantities of beta-2 receptors as well. So we see increased output, but not every organ gets increased delivery. So the autonomic nervous system, as you can see, increases the rate of conduction through the vascular, the conduction tree we just looked at. And it will also increase the rate at which the SA node fires. Sympathetic nervous system effects also increase the strength of cardiac contraction. Reason for that is that they cause increased filling. Because they cause increased filling, they stretch the muscle, you get increased rebound. So you increase the strength of contraction. Now, the parasympathetic nervous system decreases conduction rate at the AV node and decreases the rate of firing from the SA node. It, however, has no effect upon the force of contraction. That's an important difference between the sympathetic and parasympathetic input to the heart. So the sympathetic increase is due to epinephrine, norepinephrine being delivered to the heart by sympathetic nerves that innervate the heart. And vagus nerve based parasympathetic input to the heart will be largely due to acetylcholine. The catecholamines, norepinephrine, epinephrine, they cause increased depolarization. Notice how they do it. See the slope of this funny current? Notice that the slope of the funny current, and for Olivia's sake, let's draw on this to show her. Notice that the funny current slope goes up here. The reason for that is that you get, oh, for pity's sake, you get increased cyclic AMP now in those cardiomyocytes. Those HCN channels, they are influenced by cyclic nucleotides like cyclic AMP. Increased cyclic AMP increases the flow of sodium through these, that is going to increase the slope of the funny current. That increases their depolarization. Acetylcholine, however, is going to tend to depolarize the cell because it's going to open chloride channels. Yeah, that's meant to be chloride. Yeah, drawing with this mouse is hard. So you hyperpolarize those cells, that slows them down. It's harder for them now to get to threshold. That's why you slow down the heart with increased parasympathetic input. Very good. We talked about end diastolic volume. We need also to talk about total peripheral resistance and the contractibility or the strength of ventricular contraction. So end diastolic volume, that's the amount of blood in the ventricles before they contract. So at the end of diastole. Total peripheral vascular resistance. That has to do with the amount of resistance of the blood as it flows through the vessel. Now, those of you who had physics learned about resistance when it comes to electricity. Can anybody give me a poor man's explanation for resistance through an electrical cable?
It's second semester.
That second semester. All right. Yeah, use your imagination, pretend that ugly thing's a blood vessel. So you've got blood flowing through here. Some of this is going to boing, 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 like that. Some of this too here is going to go boing, 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 boing. Not going to have a straight path through. So these guys going boing, 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 boing like that, they're going to do, get out of my way. Stop it. No, I'm serious. You are in trouble. You just wait till your dad gets home, so on and so forth. So where is it going to be going the fastest? Through here. Say it again. You're a genius. No wonder you got into PA school. Through the middle. The rest of these are going to be interfered with by these shysters over here that won't get out of the way. That's resistance. That's resistance. Now, which is going to have more resistance, a shorter blood vessel or a longer blood vessel? Why? Why?
Less the travel moves with the sides.
Right, more opportunities to get interfered with. So vascular resistance is going to depend on several things. Let me just give you the equation for vascular resistance and you'll see the things right away. I don't want to overload you with math because I know it's not a math class. I know a lot of you hate math. So resistance is equal to 8 times something called eta. Eta has to do with viscosity of the fluid times the length divided by pi. Not apple or blueberry, but the numerical one, times the radius to the 4th power. That's resistance. So length goes up, resistance goes up, right? Viscosity, in fact, let's just say viscosity. Think of it this way. Big, beautiful stack of buttermilk pancakes. You take syrup, pour it. How fast does the syrup come out?
No.
kind of slowly. The better the syrup, the slower it goes. Now, let's say you pour orange juice on your pancakes. How fast is it going to come out? Fast. And I don't recommend that, by the way. Why? Because orange juice and syrup have different internal friction. That internal friction of fluid is called viscosity. What's going to influence blood viscosity?
Oh,
Sorry? No, it varies. Come on, Emma, future PA. What sort of things might influence blood viscosity?
Many form elements.
Very good. So you might have too many red blood cells. That's a condition called polycythemia. Polycythemia. Too many red blood cells, that can increase viscosity. Solute concentration, so your blood sugar goes way, 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 way up. Now blood is a little too thick. Pi, that's a constant. That's not gonna, ooh, radius. Radius goes up, resistance goes down. Radius goes down, viscosity goes. So what happens when blood vessels do this? Resistance goes up, and look how much it goes up to the 4th power.
wow.
So the flow of blood, Q, is the flow of blood is equal to pressure times resistance. Pressure times resistance. So let's say somebody has a blood flow of, say, 300 milliliters per minute. And say that's going through the carotid artery. Then they get blockage in that artery, let's say of half the artery. So radius now, 50% blockage, radius has been reduced by a half of what it was. So the radius now is 1/2. We plug that into our equation. Radius is now R over 2. That means resistance is now going to go up how many times? 16 times. 16 times. So now your blood flow drops by a factor of 16. See? See? Math is not always a bad thing. I think the math can help you think about the implications essentially of a blocked artery or vasoconstriction or something like that. All right, so afterload is defined as the stress on the left ventricular wall during systole. And I don't want to bore you with the law of Laplace and stuff like that. That's for another time or another class. So the afterload is directly proportional to the left ventricular pressure during ejection and the radius of the ventricle, so on and so forth, blah, blah, blah. For simplicity's sake, let's just say the left ventricular wall stress during ejection is proportional to the left ventricular pressure during ejection. That left ventricular pressure, that's afterload. Afterload. So that's the load you impose on the ventricle after contraction has begun. So it's going to be essentially the pressure it's pumping against. Pressure it's pumping against. So as the end diastolic volume goes up, the afterload will depend on the strength of the ventricular contraction. That means the strength of the ventricular contractions is going to increase as the EDV increases. So going back to our equation, as this goes up, you stretch the ventricle more, that increases the contraction, the strength of contraction. So cardiac muscle has a certain elasticity. As you stretch it, you increase the strength of the rebound. This is called the Frank-Starling law of cardiac muscle. And this is one of the reasons why during exercise, strength of contraction goes up as your muscles work. So let's think Sarah's running around the bases, say she got a great hit to the corner. She's just running as fast as two little feet will take her. That increased pumping of the skeletal muscle increases return to the heart. That increased venous return now stretches the ventricle. Stretching of the ventricle increases the rebound. That increases the stroke volume. Because you're increasing the stroke volume, you increase cardiac output. And that's called the Frank-Starling law. Frank-Starling law. And you can experimentally generate different amounts of filling on the heart, and you can measure the stroke volume under certain conditions. You can see as EDD goes up, your stroke volume goes up. It's not linear, and there's also a point of diminishing return, but that increased contractility is caused by sympathetic nerve stimulation. So even though the heart is beating faster, that increased filling due to increased venous return will increase the stroke volume. And this also shows it as well here. This is due to the fact that as you stretch the muscle out, you increase the amount of real estate that the actin has to make contact with the myosin. And that's why a little stretch helps you at rest, essentially. We don't have quite as much real estate, so our contraction is pretty weak at rest. But as we start to stretch it, as we increase venous return, you now increase the force of contraction as well. So there's a physiological reason for this as well, because now the actin has more ability to make contact with the myosin and form cross bridges and have a more forceful contraction. That's called increased contractility. Contractility. And contractility just means the strength of the contraction given a particular fiber length. And the sympathetic neurotransmitters, they increase the strength of contraction, whereas acetylcholine doesn't affect it at all. You can see that here. Very good. We will finish this on Wednesday. And what's after this? Respiratory, I think. We're going to skip respiratory. We're going to skip respiratory. We just don't have time. We'll skip respiratory and go to digestive, I think is next. Yeah, digestive.
All right.
All right.
All right.
And you guys are doing the digestive lab this week.
Yes, sir.
And then do urinary after that, then reproductive. Okay.
Thank you.
You are most welcome.
I'll see you on Wednesday.
Okay. Ciao.
Everyone, you must be sure.